Morning is Catherine's going to talk to us about analgesia in critically ill patients, and it's going to be great. So I will turn it over to you, Catherine, but we're here if you have questions or need anything.
Okay, am I unmuted?
Yep.
Is my screen shared? Does that look okay?
We can't see it yet. You might have to push OK or confirm it.
Oh, hold on. Oh, here we go. Uh-oh, I'm getting an error message. Screen sharing has failed to start. Please try again later. Sorry guys, hold on.
There we go.
Did that work?
Yeah, so later was
Great.
just like
Okay.
1 minute, so you're good.
Good. Okay, so hi everyone, thanks for joining. My name is Alberty, for those of you who don't know me, and I am here to talk about analgesia in critically ill patients, which I think is really important. Okay, so disclosures, I don't have any, and I want to take a moment to establish the importance of this topic, because I think it's really important, and I think you should think it is too. So pain is really common in critically ill patients especially because of their systemic inflammation, their immobility, and 50 to 80% of patients in the ICU do report pain at some point. Pain is commonly under-recognized and under-treated, which leads to worse outcomes. 25% of patients 4 years after their ICU stay that report some sort of stressful event, and pain is the number one, have PTSD symptoms at 4 years after their stay. Systematic pain assessment and management has been shown to improve outcomes. So it's important that we learn about it, that we know about it, and that we implement it. And then just to point out that pain management is different from sedation, although there's going to be a lot of overlap in some of our medications like opioids and others. And it may be that all you need is pain management in our critically ill intubated patients. So we're going to take an analgesia first approach, which is what's recommended in the SCCM guidelines. And then there's secondary benefits of analgesia too that we'll talk about a little bit. So our learning objectives for this presentation are to review the physiology of pain and pharmacology of common analgesic medications, learn about and use validated tools to assess pain in the intensive care unit, hopefully develop a systematic approach to choosing an appropriate pain regimen for patients in the ICU, obviously with the emphasis on the medical ICU, and then become familiar with this multimodal approach that's recommended, as well as the non-opioid agents in pain management in the ICU and their roles and benefits. So this is a Venn diagram that just kind of illustrates that while analgesia and sedation are different goals of care, there's a lot of overlap, and there's gonna be overlap with especially our opioids, which are a mainstay of pain management in the ICU. And just to also say that pain is different from undifferentiated agitation, and we don't want to just give a huge slug of opioids just to someone who's agitated and we don't know why, because that is associated with worse outcomes as well. So just really briefly, the physiology of pain, kind of taking it back to medical school. So as we know, pain is sensed peripherally. It goes up this afferent pathway through the spinal cord, and then into the brain, where cortical and subcortical structures are really involved in how we perceive pain, and how pain is felt to an individual. So pain is really subjective, it's complex, makes it hard to treat. However, with all of these different spots in the pathway, you've got your local mediators, you've got NMDA receptors that get excited, and then you've got your central nervous system that gives us a lot of targets for potential pain management medications. So going through this again with some targets for pain management. Centrally, you've got your opioids, your acetaminophen acting. In the spinal cord, you've got your regional anesthesia, your neuraxial block, opioids again there. And then locally, you can have local anesthetics and NSAIDs, just to show that there's lots of different ways to treat pain and lots of different targets, which lends itself nicely to this, what we call multimodal approach of pain management in the ICU. And This is recommended by the SCCM guidelines in 2018. And basically what it is it's an approach that uses multiple medications at lower doses in order to decrease the toxicity of a single medication at a high dose. And this image that I took from the Internet Book of Critical Care just shows us what we know about a lot of medications, that as the dose goes up, your therapeutic benefits at a certain point are outweighed by the toxic effects. So even though the dose is increasing, you're not getting more therapeutic benefits at the cost of having more toxicity. This is an image that just kind of shows an example of what a multimodal approach might look like in the ICU. And you've got your base of your acetaminophen, which we'll talk about more. You've got your opioids, and then considering some other adjunctive medications as you go up before we get to that opioid infusion, because we really do want to limit the exposure to opioids of our patients, and opioid infusions are associated with a wide variety of adverse effects and problems that we are very aware of. So our goals of pain control are to alleviate suffering and optimize comfort in patients in the ICU, because we know that that's associated with better short and long-term outcomes, and then use what we know in an individualized way and in the given clinical context of each patient. And then those secondary goals that I talked about earlier are attenuation of adverse physiologic responses to pain. So when a patient is in pain, you've got this rush of catecholamines that can lead to vasoconstriction, poor tissue perfusion, impaired glycemic control, hypercoagulability, immune problems, all sorts of things that we don't want to be happening in our critically ill patients. Another important secondary goal is preventing development of chronic pain syndromes, which are very common after ICU stays in ICU patients. Even if they come in without a chronic pain syndrome, if their pain is untreated, their risk of developing a chronic pain syndrome is increased. And then thirdly is to control the anxiety and agitation that's related specifically to pain in order to help our patients who are intubated or have invasive necessary devices to keep them safe from harming themselves. So we've decided that pain is important. We want to treat pain. We know that. So on the flip side, do we just want to give everybody a ton of opioids? Do we want to just snow patients? Does it matter if we snow patients? Yes, it does. And I know I said we wouldn't talk a lot about sedation, but there's evidence to show that deep sedation is associated with increased ventilation time, increased ICU length of stay, delirium, mortality. And then opioids as well, our high doses are going to be associated with tolerance, dependence, withdrawal, which we want to avoid, other adverse effects that we'll talk about, and increased ventilation time as well. There's a study that shows that transitioning someone from a fentanyl drip to methadone is associated with quicker extubation. So how do we assess pain? That's the next logical question, right? Does anyone have any thoughts? Has anyone seen pain assessed that they can speak to in the ICU? And if not, that's okay.
From
Okay.
your chat, you're hearing CPOT score is one suggestion.
Great. Love it, perfect. And we'll talk about that. I think the first place to start, a really good place to start, is if they're able to communicate, just ask them. If they're able to talk to you, if they're able to put pen to paper, you can ask them the severity of their pain. If they're unable to communicate, there are validated, reliable pain scales that we use, and someone said CPOT, which is great. There's also the behavioral pain scale that we'll talk about. And I think a question comes up a lot of vital signs. Are vital signs reliable to tell us if our patient's in pain or not? And the answer is no, they're not reliable. They don't correspond directly with patients' reported pain severity. They can remain unchanged with pain, and alone, they're not a good indicator for assessment of patients' pain. So the first pain scale we'll talk about is the Critical Care Pain Observation Tool, or CPOT for short. We use this a lot in our ICU. This looks at different behavioral indications of pain, facial expression, body movements, muscle tension, compliance with the ventilator. It's scored from 0 to 8. The behavioral pain scale is another one that's validated. It's widely used as well. And again, it looks at behavioral indicators of pain, so facial expression, upper limb movements, compliance with mechanical ventilation when they're in pain or being moved, and this score ranges from 3 to 12. So we have decided that treating pain is important. We have learned how to assess pain, and we have decided that our patient has pain and we should treat it. So the next question is, how do we treat pain? How can we treat pain? I think the first thing that maybe seems obvious is to identify and remove any sources of pain as you're able to. I have a story of a patient that I was taking care of in the ICU, and he was being proned, and he actually had COVID. And he was doing really, really well with proning historically until one day the nurses proned him and he started to buck the vent. He looked really uncomfortable. He did have vital sign changes. And after some deliberation and some evaluation by our nursing colleagues, they determined that in the process of turning him, his scrotum got pinched in the apparatus that we use for proning. So once that was resolved, he did so much better, and he actually was weaned off the ventilator, extubated, and discharged. So it's important to, even if someone can't talk to you, to take a moment and see if there's anything that you can do to help them with their pain that's obvious. And then in the same vein, non-pharmacological intervention, so removing invasive lines as you're able to, removing catheters, removing drains, stuff like that, to mobilize early if possible. That's really important, and that's associated with improved outcomes. And then there's some other things like music, massage, cold therapy, acupuncture, relaxation techniques, which are all actually in the guidelines recommended as adjuncts if they are available, very low risk. So, okay, we've done all these non-pharmacological things for our patient and they still have pain, and now we think we need to treat it with some drugs. So if you could create the ideal pain medication, the ideal analgesic, it might have some of these characteristics that you see here on this slide. So rapid onset and recovery, no side effects, no toxicity, no drug accumulation, no propensity for allodynia or hyperalgesia or dependence, and that just doesn't exist right now. So we'll talk about some of the medications that do exist and how we use them. First, I do want to give some attention to adjuncts and non-opioid analgesics because they can be really beneficial. They've been shown to help reduce the consumption of opioids and therefore reduce the toxicity that you can get from opioids. And so we're going to go through each one. We'll talk about the mechanism of action. We'll talk about advantages, dosing, disadvantages, and then our guidelines. And then just a disclaimer, I want to say a lot of this evidence is actually from our surgical and anesthesiology literature. And so just to keep that in mind. So acetaminophen, you all love it. You all use it probably every day. So it's funny that the mechanism of action is not completely elucidated. It's perhaps due to activating these descending serotonergic inhibitory pathways in the CNS. Its advantages, excellent safety profile. It's been shown to be a mild to moderately effective analgesic. It can reduce your opioid requirements and delirium and nausea and vomiting. And those trials were in post-op patients, I think specifically with IV acetaminophen. The dosing, it can be given IV, PO, or PR. Typically, we're doing 650 to 1,000 Q6. If you're scheduling it, you might want to do Q8, especially for our geriatric population to preserve their sleep. And IV is not super available in our institution, but they've shown that there's no difference between IV and PO as far as efficacy. Disadvantages to acetaminophen. Generally, in a healthy patient, you can give them up to 4 grams a day. However, in folks who have compensated cirrhosis, low body weight, under 50 kilograms, you should limit that to 2 grams per day at most. And then in neutropenia, you want to consider, are we blunting the fever that we would want to see in neutropenic patients? So something to think about when you're using it in that context. And then you should really avoid acetaminophen in any acute liver injury, acute liver failure, or decompensated cirrhosis. So our guideline recommendations do say to use acetaminophen as an adjunct to an opioid for pain management in critically ill adults. So this next medication, I wasn't super familiar with, but it's really interesting. It's not actually available in the US, but I think it's something we should be aware of. It's Nifopam. I'm not even sure I'm saying that right, but that's how it looks. Mechanism of action, it's a non-opioid analgesic. It inhibits dopamine, norepinephrine, serotonin recapture in the spinal and supraspinal spaces. It's a pretty decently strong medication. 20 milligrams are equivalent to 6 milligrams of IV morphine. And it doesn't have any negative effects on hemostasis, renal function, hepatic function, ventilatory drive. Disadvantages, like I said, not available in the US. It is commonly used in other countries. In France, it's the second most used non-opioid analgesic, second to Tylenol. It can be associated with glaucoma, seizure, delirium, and the guideline recommendations actually are to use it as an adjunct or even as a replacement for an opioid. So interesting, maybe in the future we'll have access to it, who knows. The next medication I want to talk about is ketamine. So we're probably not going to see this a whole lot in our medical ICU. It's pretty commonly used though in post-op patients. So you might see it when you're on geriatric medicine, when you're co-managing a lot of surgical patients. The mechanism of action here is that it inhibits NMDA receptors. And so if you think back to the physiology of pain, those NMDA receptors get excited and can exacerbate pain. So that's where this comes into play. Also, NMDA receptor activity is associated with opioid tolerance. So ketamine has been proposed as a way to help with that as well. The dosing here is a low dose, 0.1 to 0.3 mg per kg. This may be referred to as pain dose ketamine. At these doses, it provides pain relief without the other negative neurological effects. So hallucinations, dissociation, euphoria, things like that. It shouldn't affect the respiratory status or airway, doesn't cause hypotension, and it may reduce acute opioid tolerance, which is related to that NMDA receptor. Disadvantages are those psychomimetic effects, the hallucinations and the negative things that can happen with that, but again, shouldn't happen at that dose. And so the guideline recommendations are to use low-dose ketamine, that pain dose, as an adjunct to opioid in post-surgical patients in the ICU. However, it may have a role in the medical ICU in some of those contexts in which maybe someone is getting opioid-induced hyperalgesia and you want to decrease their opioid dose because of that or because they're getting tolerance to it. The next group of adjunctive medications is neuropathic pain medications, and we use these a lot in practice all over in clinical context. So the main ones I want to talk about are gabapentin and pregabalin. Mechanism of action here. So while they are structurally similar to GABA, they actually don't interact with GABA receptors. So they inhibit voltage-dependent calcium channels. Dosing here I have listed for you. They both need to be dose-reduced in renal dysfunction. Keep that in mind. Advantages, they're highly, highly effective for treating neuropathic pain. In fact, they were studied in Guillain-Barré or AIDP. As a very effective adjunct medication for neuropathic pain. They were also studied in post-cardiac surgery in the ICU, and they were effective in that kind of pain as well. They have a low risk of drug interactions. Disadvantages is gabapentin bioavailability is very variable from like the 20% range to like the 70+% range, and it's only available PO. It can cause sedation, dizziness, ataxia. It does have discontinuation effects. So if somebody comes in on it, they should stay on it. And then again, it's renally cleared. So it needs to be dose reduced and used carefully in renal dysfunction. And then the guideline recommendations are to use it as an adjunct to opioids in ICU patients with neuropathic pain. However, because it performed well in that cardiac surgery study, it seems like it may be able to help reduce opioid use in other types of pain as well. So this slide is just an outline and a summary of the recommendations that we just went through about all the adjunctive medications. As you can see, the strength of the recommendation generally is not super strong, and the quality of evidence as well is generally not super high. Okay, so we talked about all the non-opioid medications and the adjuncts, and now we're going to talk about the mainstay, the backbone of analgesia in the ICU is opioids. So PRN bolus dose opioids are often going to be required for pain management in critically ill patients. We would like to avoid infusions if possible, just because the toxicity increases substantially with the use of an infusion, and also our brains adapt so quickly to continuous opioids that it really elevates the risk of withdrawal and dependence and tolerance. There's also some studies in Europe that show that people can be maintained on a ventilator with little to no opioids. So it may be that we're just using too much opioids. Is that to say that opioid infusions are never beneficial? No, absolutely not. There's instances where we should use an opioid infusion, they would be indicated. Some of those are an intubated patient where we need respiratory suppression. So for example, severe status asthmaticus, someone who is really struggling to comply with the vent, and maybe somebody who, in order to save them from a paralytic, you just give them some extra opioids. That would be an indication for an opioid infusion. And then for people who are on chronic opioids prior to admission, which we could have a whole other talk on, honestly, you should have some basal amount of opioid in order to prevent withdrawal. And then when patients initially come in and you're initially stabilizing them, you know, for the first few days or so before the problems of tolerance, dependence, withdrawal become a problem, as well as dose accumulation, it's reasonable to use an infusion at that time as well. So now I'm going to touch on the reasons that we really do want to limit or just be really conscientious about how much opioids our patients are getting. The first one is respiratory suppression, and even over chronic use, this doesn't get any better with exposure to opioids. And like I said, it can be beneficial in some instances. However, it can really cause respiratory distress and failure in our patients who have chronic hypercapnic respiratory failure, like obesity, hypoventilation, or COPD. So just to be mindful of that. The second concern I'll call gastrointestinal failure. And this is referring to the effect that we all know that opioids have of slowing people down a lot. It can cause gastroparesis. It can cause problems with aspiration and enteral feeding. It can cause colonic pseudo-obstruction. In the worst case, it can cause perforation and death. So it's something to be really aware of. And then opioid dependence and withdrawal. We've already touched on that a lot. It can happen really quickly on an infusion, and then can lead to withdrawal, which is not pleasant either for patients. And then opioid-induced hyperalgesia refers to this phenomenon where despite increasing doses of opioids, their pain is actually getting worse and not better. And so that's something to think about as well. Obviously, there's other adverse effects and toxicities that I haven't mentioned here, but these are the main ones that we're going to be concerned with in the ICU. I mean, there's, you know, urinary retention, there's pruritus, there's all sorts of other things too. So we've talked about wanting to limit opioid consumption. So I want to share some strategies to help with that. So it's really important to have PRN boluses of opioids available. If you're going to start an infusion, start at a low rate. It takes infusions 4 to 5 half-lives to reach steady state. And so giving somebody an infusion is not going to immediately relieve their pain right then. And so just to be aware of how that works and be aware that it's important to have a large bolus if somebody is having pain and they're on an infusion, and then a small increase in the infusion rate. That helps us not crank up the infusion rate too high, too quick, because we're not seeing immediate relief of pain. And then another approach is to down titrate frequently in a protocol manner as able. And then again, going back to, we're using opioids for pain control, not sedation. So it's important to assess, you know, is this person pain controlled? Are they not overly sedated? Are they agitated for some other reason? And then, like we've been talking about, using adjuncts, this multimodal approach is really important to limit opioid consumption as well. So now we're going to talk about the mainstay of ICU pain management, which is opioids. You can see some examples there that we use commonly: fentanyl, hydromorphone, morphine, oxycodone. So they act on these receptors in the CNS, the mu receptor mostly. They increase pain threshold, alter pain perception, and inhibit ascending pain pathways. There's no evidence that one is superior over the other. They're all pretty similar. And so their different characteristics are going to help us choose which one we want to use. The dosing, I just want to sort of reiterate this again. The effective dose of an opioid is determined by your patient's response in front of you. So we want to use the minimum effective dose. And again, PRN boluses are really important for those reasons I talked about. So when you are picking an opioid, which one do we want to use? I know we've all got power plans and it's all in there, but I just want us to be conscientious about our choice. It becomes a balancing act of adequate analgesia and limiting the toxicity and adverse effects. It should be individualized to patients in clinical context. The way we're going to do that is we're going to think about the differences in the agents of their onset, duration of action, histamine-related side effects, and the risk of accumulation and organ failure. So fentanyl. Fentanyl is a go-to. It's a great first-line choice. We use it a lot. It's got advantages like rapid onset, short duration. It's very lipid soluble. It's really good for situational pains. So like your turns, procedures, wound care, things like that. It's easily titratable, minimal renal clearance. So it's cleared by that cytochrome P, cytochrome P 450, 350, what is it? Very low histamine release related to fentanyl. So it's got minimal vasodilation, minimal hypotension. Because it's highly lipophilic, it can accumulate in fat tissue over time, which means when you've got somebody on a fentanyl infusion for a while and you want to take them off of it, they're not going to immediately come out of the fentanyl effects because it's in that fat tissue. It's going to be released over time. And then it can cause chest wall rigidity at higher doses, which can be life-threatening. Hydromorphone is also a reasonable choice for pain management in the ICU. It can be used in patients who are on medications that alter that cytochrome P450 way that fentanyl is metabolized. And some of those medications, I had to look them up, but there's some antibiotics on there, like rifampin's on there, antifungals like voriconazole is on there. It has a longer duration than fentanyl. So if somebody is needing a longer pain relief, that's maybe not just situational, it could be a good option. And it also has a fairly low renal clearance. But it does have some potentially neurotoxic or sort of euphoric metabolites that can accumulate and be detrimental there. And its role is it's a good alternative to fentanyl. So morphine advantages, so it's not metabolized in the liver. Disadvantages, it's highly reliant on renal clearance and it has active metabolites and it has large histamine release, so it causes the most hypotension of opioids. We don't use it a whole lot in the ICU for pain, but it has a role in palliative care and purposes there. And then remifentanil is one that we don't see a lot either. It's limited use in the US due to tachyphylaxis concerns and cost concerns, but it seems like it could be a great option if we had it available, so I wanted to talk about it. So it's ultra short acting, onset less than 3 minutes, duration is 5 to 10 minutes after cessation. It's cleared by nonspecific plasma esterases to inactive metabolites, so that probably relates to why it's so short acting. And it does not accumulate in renal or hepatic impairment because of how it's cleared by these plasma esterases. The disadvantages, when it stopped very quickly, and so you might have pain, discomfort, withdrawal upon cessation. It could be used, if feasible, as an alternative to fentanyl for patients who require that really quick offset. So people who need frequent neurologic assessments or folks with multi-organ failure because it doesn't accumulate, like I said. And then just a brief note about methadone. So methadone has some NMDA receptor antagonist properties, which are associated with opioid tolerance. Which make it sort of unique in that it's helpful to avoid withdrawal and also as an alternative to alleviate opioid-induced hyperalgesia. It can cause QTC prolongation, and so that should be monitored closely if you're starting someone on methadone. And then quickly, patient-controlled analgesia. So this we don't see a whole lot in the ICU, but if you have a patient who is awake enough to use this, it's a really, really great option to have for pain control. So you set up the demand bolus and the lockout interval, and the lockout interval is based on the duration of action of the opioid that you choose. And then the patient can push that button all they want, but after it's locked out, they won't get any more. It also has sort of a built-in safety mechanism, is that if somebody pushes it and goes to sleep, they can't push it anymore. So that can help too. The thing is that it does take time to set up. So if somebody is in an acute pain crisis, this is probably not your best bet. You want to treat them with those boluses up front, and then maybe put them on a PCA in order to maintain that. The other thing to note is that they should never have a basal or continuous rate that should be set to 0 unless the patient is already on baseline opioids and you want to prevent withdrawal in that person. Oops. So this is also from Internet Book of Critical Care. This is a summary slide of the IV opioids that we've been talking about, and a few of the things, the points and the characteristics that we talked about. And also at the bottom, you'll see the PCA demand dose and PCA lockout interval for your reference. And then just wanted to loop back around to other adjuncts, local measures, kind of the kitchen sink approach. If you're kind of looking for different ways to help out your patient in pain, but without increasing their opioid dose. So we talked about early mobilization already, physical therapy. These are both shown to improve outcomes. Local things like lidocaine patches, topical lidocaine. I briefly mentioned regional anesthesia. So this would be your neuraxial block. This would be your peripheral nerve block. While those maybe are not appropriate for a lot of NICU patients, they can be if you have maybe somebody who's post-op from potentially like a amputation or something like that. They can be also good for rib fractures as well. And then those other things that I mentioned before, which I think is really cool that the recommendations, that the guidelines recommend these things. So that the hot and cold therapy, the massage, acupuncture, music therapy, relaxation techniques, things like that. And then quickly, agents that we typically avoid in ICU populations and kind of why. So IV lidocaine, there's just not enough evidence for it, and the risks at this point are seem to outweigh the benefits. And then NSAIDs. So I know I mentioned NSAIDs at the beginning with the physiology of pain on those local mediators, but considering all of their adverse effects, the effects on bleeding, the effects on artery disease, the effects on the kidneys, and considering that a lot of patients in the ICU have kidney problems and all those other problems, we generally are avoiding these altogether in the ICU. I think that there might be some role for them to play in patients who, you know, are otherwise healthy and are needing discrete, infrequent procedures, and you're really limiting the dose of NSAID. Maybe they could be a candidate for a one-time dose of ketorolac or something like that. Other opioids that we typically avoid in the ICU, meperidine, Demerol. It is rarely used in patients with renal insufficiency, which is common in the ICU, has neurotoxic effects. You might see it sometimes for other indications, for shivering with someone's being cooled, or for rigors if somebody has an infection. Codeine, we're not using in the ICU either. It's very weak analgesia effect, and the only reason it really works is because it's metabolized to morphine, so we avoid that as well. And then I think opioid agonist antagonists we avoid as well, because that could precipitate withdrawal in opioid users, and it's just not an agent that we really use in the ICU. So to wrap up, pain is subjective and complex. We want to use standardized and validated tools to assess pain in the ICU frequently and according to a protocol, because that's shown to improve outcomes. We want to use a multimodal analgesia first approach, making use of all those pharmacologic and non-pharmacologic agents that we talked about in order to reduce opioid consumption and toxicity. And you want to really individualize therapy to each patient based on that patient's comorbidities and the clinical context. And there's a couple of examples there that we kind of talked about. One that we didn't mention is that somebody with bronchospasm, so like that person with the status asthmaticus, it is probably better to use fentanyl in that patient just because it doesn't have that histamine response that some of the other opioids can have. Okay, that's all I've got. Thank you guys for tuning in. I appreciate your attention. And then this is another little summary slide and time for questions if there are any.
So while people are thinking of their questions, I can ask a couple that have come up in the chat if that's okay. So someone's curious about how much more likely development of chronic pain syndrome is after an ICU stay. I don't know if you have numbers or. anything like that in mind?
Yeah, I think I do. Maybe I might. Hold on. Sorry.
That's okay. We can come back to it if you're needing a minute. And maybe while you're thinking about that, question about, is there evidence that using things like the CPOT scale improves provider use of analgesia as opposed to just discussing the same components without explicitly using a score?
So the question is there evidence that the standardized validated systems like CPOT performs better for patient outcomes than
I think
just discussing the components?
It changes provider behavior, like in terms of ordering more analgesia or not. But feel free to chime in if I misrepresented your question.
Yeah, I honestly don't know. That's a good question. Let me jot that down actually, because I'm curious about that as well.
Yeah, I just feel like we discuss the same components of the scale on rounds without really talking about the scale, and I'm wondering how much the scale changes behavior. I saw that it changes how frequently nurses assess pain in like a quick Google search, but I wasn't sure about the provider change and like outcomes.
Yeah, I'm not sure. That's a good question.
And then any comment on what specifically discontinuation effects of gabapentin look like clinically, like what we should keep an eye out for?
Yeah, I think the main one I think of is headache, just really bad intractable headache. There might be some others as well, but that's the main one that I've seen and that I think of.
And then have you seen calcitonin used? Was another question as like an adjunct option?
So I didn't read anything about that. That wasn't in the guidelines. I've seen it used for acute, I think, and I haven't read about this in a while, but I think it's indicated for acute vertebral fractures, like compression fractures, and it has tachyphylaxis as well. So it really shouldn't be used for over, I think it's like about a month at a time, because then it starts to lose its effectiveness. I think it does have a role to play in specific patients though, for sure. And I'm sorry about that. The other question, I actually don't have a number for how much more likely they are to develop a chronic pain syndrome. My source just says many survivors of critical illness, so I'm not sure.
Another question about using methocarbamol for post-op pain as another adjunct. Did you come across any evidence for this or anything in your reading?
Yeah, so not in the medical ICU. It was not in the SCCM guidelines, and anecdotally, I'll say that I see it a lot in post-op patients as well. So they kind of like to do the methocarbamol, the gabapentin, sometimes the ketamine on top of their opioids. So I'm not sure what evidence there is for methocarbamol, but I think that there might be a role for it to play as well.
And then I think one last chat question, and other people have questions, please chime in and ask them. But I'm not necessarily talking about sedation here. You're reading, should we be continuous opioids for vent tolerance as well? I often see in the ICU that we start propofol and Dilaudid drips at the same time with the argument that the Dilaudid helps with discomfort from the ET tube before people can take propofol alone.
Yeah.
How to differentiate pain from agitation in very altered patients. Any pearls that you came across?
Oh gosh, that is hard. That's hard.
Yeah.
And I don't know that it necessarily gets easier the more you see. Hopefully it does with experience. I think that what we've got are these standardized tools, and they're not perfect, but it's what we got at this time. So I think that's the best, most protocolized way to go about it, is to use these tools. And then also, again, it's gonna kind of be trial and error, right? You try an intervention, you see how they respond, and then you go from there.
Great. Any other questions that people want to ask or follow-up thoughts? Great. Well, thanks for that talk. That was awesome and super clinically relevant. So appreciate all the work you did to put that together for us. We can take a break now to give everyone a chance to stretch their legs, get more coffee, and then we'll be back here maybe just a couple minutes before 10, and we will hear our second talk.